Hi, hi. Good evening, everyone. Hi. Good evening, everyone. So let us just start with this session. So I welcome you all to Unacademy. And before we move forward, we are going to go for a price hike. So if you are planning to buy an academy, use the code Dr. Dixit and get some extra discount now. And we have a very important thing that we have a free practice test league where we will be organizing different exams. So do give them and make the maximum of it. So before we move forward, let me tell you that we are going to discuss some very important topics for your FMG exam. So last final, you can say final round of mop up. We can say this. So let's see what are the important topics that we have. So I'll select some important topics for you people. Okay. Tell me, identify the knot shown. Good evening, Jyoti. Good evening. Good evening. Good evening. So identify the knot shown in this image. Identify the knot shown in this image. Okay. So whenever we get a question on the knots, one very important thing is that we are often not able to understand what is grannies and what is a reef on the image. So last minute discussion for you people, whether it is a grannies or a reef. So when we talk about the knots, we'll have a quick revision on this topic. So whenever we talk about the knots, there are 2-3 important things that we have to understand. Knots of open surgery are different, and knots of laparoscopic surgeries are different. Conventionally, they are the same, but technically, some difference in making them. In open, we have 2 throw knots and we have 3 throw knots. So 2 throw knots versus 3 throw knots, let us see. When we talk about 2 throw knots, what are the 2 throw knots that we have? We have a 2 throw symmetrical knot. And what is this 2 throw symmetrical knot known as? This is known as a reef knot. This is known as a reef knot. So 2 throw symmetrical knot is a reef knot. Also it is also known as a square knot. Also known as a square knot. Then we have 2 throw asymmetrical knot. So students, 2 throw asymmetrical knot. This is what is known as a granny's knot. Granny's knot. Then we have a 3 throw knot. When we talk about a 3 throw crossed knot, this is what is known as a surgeon's knot. A surgeon's knot. And then the next is Aberdeen's knot. Next is Aberdeen's knot. When we talk about Aberdeen's knot, students, what is Aberdeen's knot? Can anyone tell me? It is loop out of loop, loop out of loop knotting. So loop out of loop knotting is what is known as an Aberdeen's knot. When we talk about the laparoscopic knots, what are they? We have a laparoscopic surgeon's knot. And then we have a laparoscopic Aberdeen's knot. And then third is we have extracorporeal slip knots. What are they? Let us try to understand. What is the concept of extracorporeal slip knot? What is Aberdeen's knot? What is a reef and a granny's knot? Everything we are going to discuss here. So this is extracorporeal slip knot. We have 2 types of extracorporeal slip knots. One is a Rodder's knot. Rodder's is defined as 1 to 1. And then second is a Melzer's knot. If we talk about a Melzer's knot, it is a 2-3-2. I have my own modification. I call it a SD's modification. I use a 2-to-2 knot. I routinely use knots in laparoscopic surgery, and I use a 2-to-2 knots. Before that, leave everything. Let us try to understand how to differentiate between a granny and a reef knot. Let us see. Bache, before talking, let us understand when we want to secure a knot. Suppose this is one end of the knot and this is the another end of the knot. So suppose there are two ends of the knot and we want to secure these knots. Okay. So you need to take the right to left, left to right. How is this? Just see. The right side will go to left and the left side should go to right. The left side should go to right. This is known as crossing. Crossing. Always remember, if you do two symmetrical crossing, this is known as a reef knot. And if you do two into asymmetrical crossing, that is known as a granny's knot. But how to identify this on image? But technically it's okay, but how to identify on image? On the image, the rule for telling whether it is a granny's or a reef is select one end at a time. Select any one end. Once you select any one end, then look for symmetry. So select any one end and then look for symmetry. What do you mean by select any one end and then look for symmetry? Try to understand this. I will take you to this image. Just see. Can you see this knot? Yeah. I will discuss. I'll discuss. Don't worry. Can you see this knot? But this is one end. Let us say this is to be end A. This is to be end B. Can everyone see? Let us see this to be a center end C. If you see this thread, orange thread, so the orange is below the blue. If you see this blue, so the orange is below blue. Can you appreciate this thing? Here also orange is below. So if you see, both these threads are below this blue and therefore there is a symmetry on this side. Therefore there is a symmetry. If you see this, can you see blue is above orange? Here also, and here also blue is above orange. So bachi, what kind of symmetry are you going to see? This is a perfectly symmetrical knot, and hence this is a reef knot. Bachi, hence this is a what knot? Reef knot. Are you getting this? This is a reef knot. Any problem in understanding this? This is a reef knot. This is a reef, not a granny's. Again, I'll show you one more image so that you understand better. So I'll take one image of a knot and I'll show it to you so that you understand better. I'll share it on the screen. Just give me a minute. Because knot-based questions are always asked and 90% of the students are not able to answer. Just a minute. Okay. Try to see this knot. If you see this knot, what kind of knot it is? Just see. What is the rule? Select any one end. Now, bache, if you see this thread, it is below this or no? So thread A, this is below, and this thread is above. On this side, this thread is below. On this side, this is above. Is it a symmetrical or asymmetrical knot? This is a symmetrical knot. And therefore, this is a what knot? A granny's knot. Clear? again I will show you one more example. Let me just give me a minute. Okay. Try to see this knot. Tell me what kind of knot it is. But you see, this end, this is below. This end, this is above. Again, on this side, this end is below. On this side, this is above. What kind of knot is this? This is asymmetrical knot, and therefore it is a what knot? A granny's knot. Are you getting? So rule, I have already told you, rule is select any one end at a time. Clear? Okay, let us move forward. Next is, tell me this knot. What is this knot? What is this knot? Yes. How did you identify? But this end, this is below. Just see, this end is again below. These two ends, they are above. So this is a what? A symmetrical knot. And this is a reef knot. So I hope reef and grannies are not a problem anymore. Yes, reef and grannies are not a problem anymore. So answer for this is a reef knot. So let me select one more MCQ for this. Yeah. This year NEET PG question. Just see, those who have given NEET PG, ask them. They got a question with a similar image on leukoplakia. I'll not discuss this question. Chalo, if this is there, I'll discuss this question. Very similar question was asked. A 42-year-old chronic smoker presents with a white fibrotic patch over the lateral part of the tongue. Yeah. All except could be true. All except could be true. Acha, Aberdeen's. Bache, Aberdeen's is a loop out of loop knotting. Okay. Bache, Aberdeen is a loop out of loop knotting. Loop out of loop knotting. Let me show you a video and you will understand better. Just see. One of your friend is having a confusion in knot. So I'll definitely show you a video where you can better understand. Okay, just see, if I want to tie a continuous knot, before that, suppose if I am tying a continuous knot, yeah, so I am doing a continuous knotting, yeah. Now if I want to terminate it, I don't have a second end, yeah. Normally we have two ends to tie a knot. This is a continuous suture with a single. So what you will do? You will create a loop out of this loop. So loop out of this loop and then you pull it out. So loop out of loop knotting. What you will do? You will pull the tail in. What is the rule? Pull the tail end. Pull the tail inside the loop to create multiple loops. Just see, I'll show this to you. Suppose I'm going to demonstrate this knot. Just try to see. So if I am doing a continuous suturing, I have taken one suture and then I have taken one more suture. Just see. So suturing, I am doing one after another, one after another. Now I want to terminate this suture. I want to terminate this suture. So what I will do, just see, I will create a loop and I will pull the tail. Can you see? I will pull the tail. I will pull the tail. Did you notice this thing? Did you notice this thing? This is a loop that I have created. This is a loop that I have created. And now just see, I am pulling the tail. Just see, the tail will be pulled off. Just see. Just see. Yeah, this is, the tail is pulled. Can you see? I have pulled out a tail. So I have created a loop out of loop. Is it clear up till here or no? Loop out of loop. And then just see, I'll create multiple loops. Again, I will pull the tail out of this loop. So I'm creating loops and I'm jamming the knot. But this act of creating loop out of loop is known as Dundee jamming. This is known as Dundee jamming, and finally, I will pull this last thread out. Just see, I have done lot of loops and now I will take the loop out and terminate it. But this is known as Dundee jamming and Aberdeen's knot. Why it is known as Dundee jamming? Why it is known as Dundee jamming? This is known as Dundee jamming, Aberdeen termination. Aberdeen termination. Why it is known? But this knot was discovered in Scotland. And in Scotland, if you see the map, Dundee is the northernmost point. So we start with Dundee jamming. First we do jam and then we terminate it at the level of Aberdeen. So Dundee jamming, Aberdeen termination. Over the time, it is commonly known as what? Aberdeen's knot. Is it clear? I will also show this knot. I'll also show this knot to you people. Just see, I'm doing a gastrojejunostomy. So I'm doing a continuous suturing. So this is a case of gastrojejunostomy where I'm doing a continuous suturing. Why I'm telling you about knots? Don't mug up. Knots are not to be mugged up. Can you see I'm doing a continuous suturing? And then I want to terminate the suture. I have closed it and I want to terminate. Students, can you see I have created a loop? I have created a loop with my 3 fingers. Loop. Yeah. And now just see how I will doing. So I will be doing a Aberdeen termination for you. So loop, I will pull the tail. Can you see I pulled the tail and locked it? Again, those who couldn't see, just see. So this is a loop, and I will pull the tail. I pull the tail. Again, I will pull the tail out of the loop. Again, I will pull the tail out of loop. Can you see I'm pulling the tail? And then finally, I will do an Aberdeen termination. So Dundee jamming and Aberdeen termination. This is how this is done. I hope now the knots are clear to you people. Yes. Laparoscopic knot, not important for FMGE at least. In my routine classes, I teach routinely. Okay. Let us discuss the second question. A 42-year-old chronic smoker presents with a white fibrotic patch. I hope knots part are clear. With a fibrotic patch over the lateral part of the tongue. What is this? Bachi, what is this? This is leukoplakia. Leukoplakia. So point number 1. If we talk about leukoplakia, what is it? It's a white fibrotic patch. Everyone knows that it's a white fibrotic patch. The second very important thing that we all have to understand is leukoplakia is of 3 types. What are the types of leukoplakia? What are the types of leukoplakia? We have a nodular type. We have diffuse type. And we have speckled type. So nodular type, diffuse type and speckled type. If you talk about the worst prognosis, the speckled variety, this is associated with worst prognosis. So worst prognosis leukoplakia. Worst prognosis leukoplakia. But overall, it is erythroplakia, which is the next. I'll tell you. Next is, let us talk about certain pre-malignant lesions, of the oral cavity. So let us have a quick rapid fire discussion. Yeah, that is what is diffuse type is. Okay, diffuse, nodular and freckled. Let us talk about something about the oral cancers, and then we'll discuss a lot of things here. But the most common malignancy, answer is SCC. The most common site overall, what is the answer, students? Overall, it is the tongue. So overall tongue, and it is lateral two-third of the tongue. Lateral two-third of the tongue. Now overall we have seen tongue. But in India, what is the answer? In India, we eat what? Kamla Pasan, Vimal. Yeah, Bolo Zuba Kesari, isn't it? Yeah, Pan Bahar, Pan Vilas. So what will happen? We stuff it in the buccal cavity. So it is the carcinoma of the buccal cavity. Then, what about the prognostic factors? The most important is lymphovascular invasion. So lymphovascular invasion is the most important. Lymphovascular invasion. Yeah, that you can say gingivobuccal sulcus also. So lymphovascular invasion greater than depth of invasion. Then we have grade also. Yeah, grade, mitotic count, all those things. Yeah. Next is the cancer with best prognosis. Can anyone tell me the oral cancer with best prognosis? The oral cancer with best prognosis. Answer is CA hard palate. The cancer with worst prognosis. Can anyone tell? Why India mein bolo Juba Kesari? What is that? Buccal. So CA buccal cavity. Next is, what about the pre-malignant lesion? Just a minute, students. Pre-malignant lesions. When we talk about pre-malignant lesions, what are the important ones that we have, students? The first is we have leukoplakia. Yep. Do you know on HPE what do you get to see? We get to see parakeratosis. Then second we have erythroplakia. But on HPE you get to see disc keratosis. Now you can understand that disc keratosis is one step more degraded than the parakeratosis, and therefore erythroplakia is the most pre-malignant lesion. Just see the difference. Most common pre-malignant lesion is leukoplakia. So most pre-malignant lesion is what? Erythroplakia. So if you read this, associated with disc keratosis, no. It is associated with, this is leukoplakia, this is associated with parakeratosis. Associated with SCC, yes. Long-term complication is SCC, squamous cell cancer. Are you getting this point or no? Then third very important thing is, we have chronic submucosal fibrosis. Now when we talk about chronic submucosal fibrosis, what are the important things that we have to understand? Oh Radhakrishnan, but a square knot is a reef knot. Surgeon's knot is a 3-throw knot. The chronic submucosal fibrosis is associated with exposure to chronic irritants. Exposure to chronic irritants. When you talk about exposure to chronic irritants, how can you define this? बच्चे example is smoking, smoking, betel nut, smoking, betel nut. Then you can say pan masala, even ill-fitting dentures. Ill-fitting dentures. What else? Spicy food. Spicy food. All these things. So, bache, exposure will cause trauma, and trauma will be associated with healing, and you know healing is equal to fibrosis. And after this, if there is re-exposure, so there will be again trauma, and one fine day trauma healing cycle will convert into what? Dysplasia. This is the logic. This is how the things are. Are you getting? The next very important thing is, what do you see? This is associated with two things. Bamboo-like stiffened tongue. What is this known as? Ankyloglossia. So the questions have been asked. Ankyloglossia is associated with, answer is chronic submucosal fibrosis. And then invasion of pterygoids, fibrosis of pterygoids. What is that? Lockjaw or trismus? Trismus. Are these things clear to everyone or no? Yes. Actually, one very important thing is on the staging and the management. Diagnosis, investigation of choice for oral cancers. Answer is biopsy. It can be punch, it can be incision, it can be excision biopsy. Now the question is, investigation of choice for staging. Now who will tell me this? Investigation of choice for staging. Tell me. For staging, tell me students. Answer is PET CT is the best. Better than MRI. Better than CCT. Is that clear? The next very important thing that we all have to understand is, this is PET CT greater than MRI. Yeah. Now staging. Staging. If we talk about staging, you get a lot of questions on TNM. So T1 is defined as less than equal to 2 centimeter or depth of invasion. Depth of invasion less than equal to 5 mm. T2 is defined as more than 2 up to 4 centimeters or depth of invasion more than 5 up to 10 mm. You get straightforward questions. T3 more than 4 centimeter or depth of invasion more than 10 mm. Excellent, excellent Venkat. What is T4? It is any size with local invasion. Any size with local invasion. When you talk about local invasion, what are the 2-3 important points that we have? Into skin, into mandible, into the floor of the mouth. The answer is, it is T4A. What is T4B? This question also has been asked. Into muscles of mastication. Into muscles of mastication. Students, what is the concept of N? N1, you know, in head and neck, it is the size of the lymph node which matters a lot. So N1 is defined as solitary lymph node less than equal to 3 centimeters. N2 is defined as N2A, solitary lymph node more than 3 up to 6 centimeter. N2B, multiple lymph nodes but none of them should be less than what? More than 6 centimeters. N2C is defined as bilateral lymph nodes less than equal to 6 centimeters. What is N3 then? Any lymph node more than equal to 6 centimeter. There is something which is known as ENE, that is extra nodal extension. Extra nodal extension. Students, when we talk about ENE or extra nodal extension, what are the important things that we all have to understand? Less than equal to 3 centimeters, it is N2, and N3 is defined as more than 3 centimeters. That means a tumor tissue moving out of the lymph node also. That is what. Next is, what is the treatment part? Let us try to understand the treatment. If you talk about the treatment of pre-malignant lesion, PML, versus treatment of malignancy. So treatment of pre-malignant lesion, which in oral cancers, generally oral cancers, level 1, level 2, level 3. In CA tongue, 1, 2, 3, even 4 may be involved. Even 4 may be involved. So level 1, 2, 3 except for CA tongue, where even level 4 can be involved. Yashdeep, not in Bhopal and Indore, but yeah, in other states we have. Maybe next year we come up in Bhopal and Indore also. Yeah, very soon will be. But anyways, if you want, you can come to Delhi. That will be the closest center for you. Yeah. So you can come to Delhi to have an experience of offline. So not this year, Bhopal and Indore, but maybe next year we may plan it for. Yeah. But yes, you can come to Delhi, or you can go to Gautam Nagar. It's there. It's there in Gautam Nagar. Yeah, it's there in Gautam Nagar. In case you have any query, you can just call. You can just WhatsApp me on this as my personal number. I'll help you out. Okay. Just. So we got a huge response. I'm thankful to all of you. We have already majority of the centers. We've got a good batch strength now. So thankful to my audience and thankful to the medical students who have come up with an acceptance and broken the taboo. So yeah, you can, in any ways, if you have any query, you can just WhatsApp me and I'll connect you to the team also. So pre-ML, what is the management for pre-ML? Let us see. Pre-malignant lesion. It is surgery, and the surgery that we do is wide local excision, WLE, with 0.5 centimeter margin. 0.5 centimeter margin. Yeah, definitely HD. Definitely. Promise. You can connect to me on this number after class. HD, you can connect to me on this number after class. You just save my number. Or, so wide local excision, or you can also go for topical 5-fluorouracil, or you can go for even laser ablation also. When we talk about malignancy, what are the important things? That we have? Malignancy, if we talk about, one very important thing is wide local excision. I'm going to Mumbai. I'm coming to Mumbai on 5th of May. On 5th of June, I'm coming to Mumbai. So wide local excision with 1 to 2 centimeter margin. Along with that, SOHND. What do you mean by SOHND, students? Supraomohyoid neck dissection. Now there are a lot of things to be asked in supraomohyoid neck dissections. Students, what are the lymph nodes that we remove in the supraomohyoid? We remove level 1, level 2, level 3. This is what is removed. Plus minus radiotherapy, plus minus chemotherapy. Always remember, we give cisplatin, 5-fluorouracil. This is what is the classical, and leucovorin. This is what is the regimen that we give. And remember, chemotherapy is for advanced cancers. When we talk about radiotherapy, students, you get 2 questions. This year also, I think there was a question on radiotherapy. People used to make fun, ki, sir, why you are teaching all these things in depth? But see, because I know the field, I know which topic is important, because I have been in this industry for now more than a decade. So if you see radiotherapy, there are 2 questions that can be asked. The regimen is 60 grays over 6 weeks in the weekly divided doses. The next thing is, so one is radiotherapy regimen. The next thing is, what are the indications? And this was the question asked. What are the indications of radiotherapy? Answer number 1, T3 and above. If you see the T3 and above, but exception to depth of invasion is more than equal to 4 mm also you will go for. Update, N2 and above lymph nodes, tumor free margin less than equal to 1 mm, or you can say less than 1 centimeter. And 5th is in case of relapse. Students, quickly, no. Benedict, I am associated with Unacademy for my online lectures. So I will always be associated with online in Unacademy. Offline, I have started my institution, that is by the name of Global Academy of Medical Education. You can also join the Facebook club also. That's by the same name of Global Academy of Medical Education. Lot of activities for the students, and it's offline is game is totally offline, and because lot of students used to request to start offline, and since because of COVID we couldn't start, but now we have already started it. So yes, in Delhi you can go to the classroom and have an experience. We have lot of things. I have shared my number also. You can always come and meet me personally also. Many a times I am often there in the center also. Yeah. So just a minute. Okay, so you can come whenever you want. I've shared my number also, and I'll be there for personal mentorship. So don't worry. Be it Unacademy, be it game, I am always there with you people. Next is, we get a question on lymph node dissections. Achha, let us do one more question. Tell me this question. What is this incision made? What is this incision made? Any idea about the incision? Yeah, let us discuss this thing. Okay. Whenever we talk about incisions of the breast, for breast, we also have a FMGE batch also, which is starting FMG and TND batch also. Okay, so you can just experience the offline and then you can join. So incision of breast, this is defined on the indication. If it is for the benign cause, or if it is for the malignancy. But the aim for benign cause is cosmesis. The aim for the malignancy is the exposure. Yeah. So exposure is there, cosmesis is there. So if you talk about these incisions for the benign cause, we have 2 types. We have circumareolar, This incision is known as Webster's incision. Students, there is one more Webster's flap. Webster's flap is for what reconstruction? Lip reconstruction. Then we have inframammary incision. If you talk about inframammary incision, what is that? This is known as Gallard-Thomas incision. So Gallard-Thomas incision. So we have inframammary, we have Gallard-Thomas incision. Okay, let us see. When we talk about the exposure, let's say we make elliptical incision. So there are two types of elliptical incisions that we come across. Either it could be elliptical transverse, which is, this is what is known as Stevert's incision. And we have elliptical oblique incision. This is known as OR incision. So we have OR and we have Stevert. Students, let us try to understand these incisions. If this is the breast, this is the nipple areolar complex, we'll make the incision along this. What is this known as? This is known as a Webster's incision. So this is Gallard-Thomas, this is Webster's. The next is, if you talk about the tumor, so if you want a complete exposure, maximize the exposure, you make the incision like this. This is known as a Stevert incision, classical Stevert incision. If the tumor is in the upper quadrant, then that incision is known as a OR incision. So this is a Stevert incision, this is an OR incision. Remember, O for OR and O for oblique. This is Stevert, remember transverse. This is how you have to remember it. Is that clear or no? Yeah. If you see, I'll show this incision also to you. The classical incision that we see. This is a classical specimen. This is a classical specimen of this. Okay, just a minute. Just see. This is a classical Stevert type incision made specimen. Can you see? This is a classical Stevert incision. Stevert. Oblique is totally different. Just see. This is Stevert. This is a Stevert. Had the specimen oriented like this, then that would have been oblique incision or Webster's incision. I'll just quickly show you this incision. Just a minute. I'll just try to see this. Can you see? This is a classical Stevert incision. This is a classical Stevert. I've already made two incisions for this. There are two outlines with marker. I tried to see with which incision it is coming. If you see, there is an outline of this. So this is a Stevert. This is a classical Stevert incision. Okay. So okay, this is all for the day. There's some problem with my app. Anyways, so this is all for the day, and I hope you enjoyed. Do subscribe to Unacademy. Use the code Dr. Dixit. It's a wonderful platform, and do recommend your friends also about Unacademy, and try to join as many as possible. Share the links of the class with your friends also. Till then, bye bye. I hope you enjoyed this lecture of mine.